dozens of cardiovascular specialists from around the world are in New Orleans to kick off the American College of Cardiology's 60th annual scientific session and the Innovation and Intervention Summit. Welcome to CardioSource Video News. I'm Dr. Randy Martin, and this is day one of a three-day blitz of late-breaking clinical trials and cutting-edge scientific sessions here at ACC.11 and the I2 Summit. And we're going to be bringing you the latest breakthroughs, and we'll also interview the key clinicians and leaders in the college. And I'm very pleased to be joined once again by our outstanding panel of experts. They really are outstanding. They didn't pay me to say that. Outstanding panel of experts. The first is Dr. Peter Block. Peter, as you know, is Professor of Medicine and Director of the Structural Heart Program at Emory University Hospital in Atlanta. Then Dr. Christopher Cannon. Chris is Associate Professor of Medicine at the Harvard Medical School and the Brigham and Women's Hospital. And Chris is also Editor-in-Chief of CardioSource Science and Quality. And last but not least is Dr. Tony DeMaria. Tony is Professor of Medicine at the University of California in San Diego. And Tony is also, as you know, Editor-in-Chief of the Journal of the American College of Cardiology. Well, esteemed panel, I'm glad to have you, glad to see you again.
I didn't pay you enough.
Yeah, well, I had other adjectives that I could have used, but I decided not to. But, what are you looking forward to in the meeting generally and then today? Peter, I'll start with you.
Well, it's a teaser morning, and partner is the big deal coming up. And I think the important thing to remember is that at TCT, we heard about partner non-surgical patients against medical therapy, and that was sort of a layup. Now we have a non-inferiority trial against surgery and transcatheter valve replacement. It'll be interesting to see how it comes out. All of us sort of hope that the transcatheter valve will win, but it doesn't really have to win. It's just going to be a non-inferiority trial. So we'll see. I don't know.
Chris, what do you think?
Well, this has been a big change already in practice. We were one of the partner institutions, and we have people being sent all over for the partner B of the inoperable patients. And it's really transformed care for these very sick patients with aortic stenosis, often with multiple comorbidities. A tough group, but a big new option for them. And so whether that applies more broadly to have a percutaneous option will be very exciting to see.
Tony?
I think there are a couple of things about the partner trials. First of all, are these percutaneous valves going to go the same way as angioplasty? First it was single vessel and then double vessel, and now it's open to almost all coronary patients. So we start with the percutaneous valves only for patients who aren't candidates for surgery. Is that ultimately going to go to a match between any patient with aortic stenosis? The other thing that's interesting is that the PI, the presenting person for partners, is a surgeon, Dr. Craig Smith. And it's interesting because that gets into the interface of cardiology and cardiac surgery with these percutaneous valves.
And go ahead.
Well, I think there's a very important thing that'll come out of this. And these are all very high-risk patients, STS scores of 10 to 15. So one of the things that we're going to learn from this is exactly what Craig Smith, I think, is going hopefully to say, and that is surgery may not be so bad for these folks. We may be surprised by how good the surgeon's outcomes are compared to what we think they might be for high-risk patients. I mean, that's going to be one of the issues.
If that happens, go ahead, Chris.
Well, I think the other aspect of this is that this is the second time where it's more of a team and that everyone is there together. And these are often patients that you're not rushing off to do surgery because of comorbidities sometimes, and so sorting out as a team, this might be someone good for surgery, this one, let's try the valve because there's, bad lung disease or other aspects. And so I think a team approach has really been emerging, that much more collaboration to sort out what's best for patients.
It may give us a lot of options for our patients that are high risk.
I think they're going to also be looking at cost. There's some kind of the second portion of the presentation is cost.
Right. And that'll be very interesting because obviously these devices, I think they're in the $30,000 to $50,000 range to put in, and so the device itself is probably going to be the equivalent of the whole surgical procedure. And I think the follow-up is going to be important. If there's more medical follow-up, with the percutaneous valves, then that's going to be very costly.
But it's, I mean, I think as you all have said, it's already changed the thinking of, you know, the cardiology fellows and young cardiologists are all saying, well, I'll put in a, you know, a valve now because if you need another type of operation, you might need one of these. This is a different question than what they're looking at, but the excitement over this technology, I think, is palpable, really.
But you make a really good point. When we published, or it's in press, a series, quite a large series of patients with valve-in-valve. And it's kind of changed my thinking about
Absolutely.
whether to put in a bioprosthesis or a mechanical valve now, because if you put in a bioprosthesis, then that patient's a candidate for a percutaneous valve.
I think it's a. Why don't we? We're going to take a break. Not that we couldn't talk all day here about this, I know, but they don't want us to. So we're going to take a break, and we're going to be right back to continue to look at some of the upcoming highlights of the meeting.
Stay tuned for the latest coverage from ACC.11 and I2 Summit 2011.
Well, immediately what we noticed is patients telling us that they really preferred the radial approach. When we first started doing this, they came to us expecting that we would be doing this via the femoral approach. They came expecting a prolonged bed rest time. They even warned us. They said, look, I've got a lot of back problems. I'm going to have trouble laying flat. And when we started doing it from the wrist and they were able to get up and ambulate right away, they were really thrilled.
Welcome back. I'm again joined by Doctors Block, Cannon, and DeMaria. Sounds like a law firm to me, but you know, we've just got through talking about the partner trial, and before we went to break, Tony, you were twitching down there. So, do you have something else you wanted to say?
Well, no, for the panel, it just strikes me that these valves are available and have been used in Europe. I understand thousands of them have been put in. And here in the United States, we're waiting with bated breath on the partner trial. We're out of sync here. Peter, Chris, are we too stringent in the United States, or are they
Tony.
cowboys in
Oh,
Europe?
my God. Don't go there, Tony.
You want to talk about the budget deficit? Is that what you want to talk? So what do you think?
Well, I think the short answer is yes, but one of the interesting things about the European data is we have so much information from Europe already, and now we have a randomized trial which gives the other perspective. But if the two superimpose and we in fact have data which supports each other, then I think we really have a solid foundation to moving ahead with this technology. My guess is it's a good thing that we're careful, but on the other hand, we are behind, no question.
Chris, you want to jump in on that?
Well, you know, from many perspectives, the SDA has taken safety to the nth degree,
Right.
and I think that one can be overly cautious, and that holds back, you know, treatments that could be available. It's always good to be careful in general, but sometimes it does hold back innovation.
You sound
Maybe
like a
that'll change.
senator at a hearing.
Yeah.
Go ahead.
Although you could
No,
say
I mean-
if the partner trial were absolutely negative, if half of the TAVIs embolized, then we'd be looking at these
Saying, aren't we,
Europeans and
yeah.
saying, what were you doing without data?
And speaking of what were you thinking about? What else are you thinking about at the meeting? Because there are a lot of other interesting trials going on.
Well, I personally think the rival trial comparing radial with femoral catheterization is going to be practice changing, and I base that not so much on the trial, because I don't know the results at the moment, but rather on the fact that is the rule throughout most of the world,
right.
except in the United States, where it's actually less than 10%. And so I suspect that the United States will move that way and that rival will be positive.
Well, it's interesting. I admit I'm not a radial guy, and I've done.
I wouldn't have known that by looking at you.
I've done a lot of radials, but I just think it is safer to do it from the femoral artery, not because a regular diagnostic cath can't be done easily and safely from the arm, but if you get into trouble doing a percutaneous intervention, it's really hard to bail out from the wrist. But we'll see what the trial shows us, you know, and
Yeah.
we'll figure it out.
Chris?
We probably will change the way we think about things, though. I would agree with you.
Chris, you got any other things?
Well,
you're
it's a learning process that people have done the femoral approach for so long that really do have to learn, and unfortunately, during that process, people can have some bad outcomes. So hopefully it'll be a progressive, starting with lower risk, diagnostic cases and leaving the higher risk ones, for a more standard approach.
What
I will
about
tell you that patients
patients are going to
love this.
Oh yeah, absolutely.
Right? They go home in 2 hours and they're smiling and they can walk.
Yeah.
It's really nice.
Yeah, and there are less bleeds, and there's no question that at least statistically, bleeds do correlate with adverse events.
All right, let me jump in. Other things, there are a lot of neat other trials going on in late breaking. Give me some other examples, things you're looking
I
forward
think
to.
Magellan with rivaroxaban, we're going to see, this is for DVT now, which is for most of us a lesser indication than atrial fib, but nevertheless, most of these patients who had DVT apparently were not post-op. They were congestive heart failure and settings where we would be taking care
So
of
the
those
whole
patients.
concept of an oral versus an IV
Well,
agent.
that, in this medical population, often the medical ICU, people sit around there for days with various conditions, and so that's a setting where one can certainly develop DVT and then PE.
Hey, it's an oral drug.
And
right?
so, it'll look at both the, sub-Q low molecular weight heparin versus oral, and then also an extended duration. They're taking a pill, they're going to give it for 5 weeks to see whether that could improve the longer-term prevention. May not be relevant if people are out of the hospital, et cetera.
I didn't like that aspect of the trial, because what they did is they have 5 weeks of rivaroxaban and they only have enoxaparin for 1 week, where most of us would put that patient on warfarin, I would think, at the current time. So they've proven that rivaroxaban is better than nothing, but I'm not sure that they've proven it would be better than Enox and then warfarin.
Let me ask you the Stitch trial, because we were chatting about that. Tell me about the Stitch trial.
I think the Stitch trial is an interesting trial. We are interested in whether surgery versus medical therapy for people that have ischemic or dead myocardium really is good, and which is better of the two. And I do personally a ton of PET scans to find out whether or not people have viable myocardium, and if they do and they have a long, and I can't easily do a percutaneous intervention, I just send them off to surgery. Now the question, hopefully answered by Stitch, will be, does that make a right strategy? Is it better to send them to surgery or treat them medically? It's a fascinating area that we think we know a lot about, but in fact there has not been a trial about.
And the population base is going to grow.
Yeah.
I mean, we know that.
That's
Chris,
right.
what do you think
Well,
about
I've
the
got
Stitch?
someone in the midst of this who just had his PET scan that was wildly positive for unsuspected viable myocardium. So I guess I can use this to guide. And it's nice to have randomized trials of questions that we face, once a week in this type population when we're, on service. So.
Well, you're not going to get to say anything. I'm sorry. We're going to have to close
I don't
out.
have anything to say.
Well, that's why I looked at you and I could tell that. So we want you to check back with CardioSource Video News throughout the meeting, and we're going to be bringing you the latest breaking news, plus you're going to hear from the primary investigators and the newsmakers. And as an extra added bonus, you'll get analysis and opinion from our expert panel. Thanks for joining us. I'm Dr. Randy Martin.